I'm Sean, and this is baby Lucy, and today we're going to walk you through how to do a head-to-toe assessment on a newborn. The first assessment that baby Lucy is going to get is going to be at 1 and 5 minutes post-birth. They're going to do an Apgar score on her. An Apgar is scored in 5 different categories. They're going to be checking her heart rate, her respiratory effort, her muscle tone, her reflexes, and her color. Each of these categories is scored between a 0 and a 2. 0 being absent or flaccid, and 2 being present and strong. We want baby to have a score of 7, 8, 9, or 10 at 5 minutes. If baby has a score of 6 or less, we're going to retest her again at 10 minutes, but that's also going to tell us that some emergency interventions are probably going to be needed. So after she does her Apgar, they're probably going to get her with mom and have her do some skin to skin, but the first real assessment we're going to do is going to start with some vital signs. So the first thing we're going to do is check baby's heart. So when baby's asleep, her resting heart, a normal heart rate on an infant is going to be 120 to 160 beats per minute. If baby's crying, it's probably going to get up to about 180, and if she's sleeping, it's going to be down to probably about 100. So first thing we're going to do is listen to her heart and make sure we get a good listen. And then we're going to watch her respirations. So first, we're going to use the bell of our stethoscope. We're going to listen, and baby Lucy is asleep, so she's coming in at 110 right now. We're also going to watch her chest and count the respirations for a full minute. Now babies are going to breathe 30 to 60 respirations per minute. When baby's asleep, it's going to be pretty slow, but we want to remember that babies also have, sometimes they can have a pattern of periodic breathing. So that happens more when they're awake. And it's going to be a period of apnea that lasts between 5 and 15 seconds. And it can be kind of scary for mom. So we just want to go ahead and reassure mom that it is a normal thing that happens. But we want to make sure we count baby's respirations for a full minute, so that way we can get an accurate count. And again, a normal respiration for a baby is 30 to 60 breaths per minute. We're going to take her temperature, and we're going to take her axillary temperature. And her axillary temperature is going to be found right here in her armpit. And we want that to be between 97.7 and 99.3. So you're just going to take the thermometer and put it right there in her little armpit and hold her arm against her body so that we can get an accurate reading. Now we could do a blood pressure on little Lucy, but it's not typically done. If we were going to do a blood pressure, we would do it on her thigh. And a normal blood pressure for an infant is going to be 50 to 75 over 30 to 45. But like I said, it's not typically done. We're going to take our tape measure and we're going to measure Lucy's head circumference. We do that. And then we're going to measure her chest circumference. And these measurements should be pretty clear or pretty close to each other. I'd say about 3 centimeters off of each other. If we have a big difference, then that's something that we might need to investigate a little bit further. So we went ahead and we did her chest. Now we're going to measure her length. We're going to have baby Lucy lay right here. We're going to have our pen, and we're going to make a mark right here on the paper. And then we're going to extend her leg all the way out and make another mark. And then we're going to use our tape measurer and measure that distance, because it's just a little bit easier than trying to get this wiggle worm to stay still. Baby is typically weighed right after birth, but they are going to weigh her again when they bring her in for a checkup. And we want to just make sure that baby is gaining weight every time she comes in to get checked. So let's keep her nice and warm. We're going to start with our neuro exam. So we're going to check Lucy's eyes. I'm going to sit her up so she goes ahead and open. And they're symmetrical, they're clear, there's no discharge. There's no yellow undertones that could indicate jaundice, so she looks good. Sometimes babies are going to periodically jerk or twitch, and that's a total normal sign, so we just want to go ahead and again reassure whoever's caregiving for baby Lucy that that is a normal finding. we're going to check Lucy's reflexes. So there are a few reflexes that we need to be checking here. So first, we're going to put a glove on her hand. We're going to take a finger and we're going to check both Lucy's gag reflex and her suck reflex at the same time. So we're just going to put a gloved finger into Lucy's mouth and push up against that palate. While we're doing that, we can make sure that her palate is intact also. Feel around in there, make sure there's nothing going on. She's probably going to give me a really good suck. And then we're just going to palpate for that gag reflex as well. After that, we're going to do her Moro reflex, or her startle reflex. So we're going to pick Lucy up, and then when we put her back down, we're going to tilt her a little bit further down such that she's going head first. So we're going to place her down, and this is going to get her to startle for us. So we're going to put her down, and she's going to excite her limbs, and then she's going to bring them back in. And sometimes the hands will kind of curl like this. So she's going to get excited and bring them back in. That's going to show us that she's got that startle reflex. Next, we're going to do her Babinski reflex. We're going to take her little foot and just give it a good stroke up, just like this. When we do that, Lucy's feet, her toes are going to fan out, and her big toe is going to go up to the sky. And that's going to tell us that she's feeling that going on down there. We're going to check her tonic neck reflex. We're going to turn Lucy's head to the right, and when we do that, her right arm and her right leg are going to extend, and her left arm and her left leg are going to contract. So that just means whichever direction we turn baby's head, say we turn it to the left, her left arm and her left leg are going to extend, and that's going to show us that she's got that tonic neck reflex. When we do her suck reflex, we want to remember mom's breast milk probably hasn't come in yet, and so her breasts are probably going to be engorged, and that just causes swelling and tightness of the breasts, and we want to encourage mom to breastfeed while she can, so that will get her milk to let down. If she has baby on the nipple and baby is sucking, not only is that going to get baby's suck reflex to go, but it's also going to kick in that milk letdown, and it's going to help mom's breasts not become so engorged, because that can be rather painful. We're going to check baby's palmar reflex, which is my favorite. You take a finger and you put it in baby's hand, and she's going to wrap her little fingers around it, and we're going to hold hands. We're also going to check her plantar reflex, which is the same thing, and take a little finger and put it under her little toes, and she's going to grip onto it like a monkey. And that's going to show us that she's got that plantar, and that palmar reflex. So we're looking at Lucy's head. We notice that her ears are symmetrical. Her nose is right where it needs to be. Her nostrils are symmetrical. And it looks like she's got some patency. I don't see anything in there, so she looks good. We're going to make sure that we look at her head, just make sure that it's the shape that we want it to be. She might have a little bit of molding going on. With molding, that's going to be the pressure from the birth canal. And the baby's going to take on an oblong shape because it's been, especially if she's been vaginally birthed, she's going to have a lot of pressure on that, and it's going to cause her sutures to kind of overlap. So we're just going to check her sutures and see how they are. And overlapping sutures are a normal finding on a newborn. So again, a lot of this is reassurance for the caregiver that baby's going to be just fine. Sometimes we might see caput cicadineum, and with caput, you're also going to have some swelling of the baby's head. The important thing to remember with that is caput is going to cross that suture line. It's just some swelling, and it'll go down in a few days, as opposed to a cephalohematoma, which is not going to cross the suture line, and that's going to be more of a bruise. It's going to have blood in it, and that blood's going to get reabsorbed back into baby's body. Again, it's not going to cross the suture line, and baby's going to be just fine. It's really not anything to worry about. So her sutures look good. We're going to assess her fontanelles, or her soft spots. So the one on the front is going to be a diamond shape, her anterior fontanelle. It's going to be a diamond shape, and it's going to close at about 2 months of age. I'm sorry, 18 months of age. So that front anterior fontanelle is going to close at 18 months of age. This one on the back is going to be triangular, her posterior fontanelle, and that's going to close at 2 months of age. Because when baby starts sitting up and doing all the things, she's going to be top heavy. So she's going to go back, and we want to make sure that that soft spot is closed at 2 months of age. So again, her posterior is going to be triangular shaped, and it closes at 2 months. And then her anterior fontanelle is going to be diamond shaped, and that's going to close at 18 months. So her ears look good, her nose is midline, her mouth looks good, her lips are awesome. We're gonna go ahead and open up and check out inside, make sure that those mucous membranes are pink. We're also looking for signs of jaundice when we do this. We're looking at baby's eyes, around baby's nose, and we don't see anything. So we're gonna keep going. We're gonna check if with those fontanelles also, we want them to be flat. If they are bulging, that could be a sign of increased intracranial pressure. We don't want that. And if they're sunken, it could be a sign of dehydration. Both of those things are medical emergencies, and we're going to need to get HCP notified right away. So now we're going to check baby's skin. So we're going to pinch her right here and get some turgor, and that's going to tell us, that's also another sign to see if she's hydrated or not. And she's good. She looks nice and pink because she's not fresh out of the oven. Right after baby's born, they can have some arcocyanosis. And arcocyanosis is a totally normal thing. Baby's peripheral circulation is still really immature. So in the fingers and the toes and the hands and the feet, she's gonna have some bluish tones. And that's totally fine. We wanna make sure that baby's trunk and baby's stomach, that's where right after birth, we wanna make sure that we see that pink, and that's why she's getting the oxygen. Her hands and her feet, they're gonna perfuse quickly, that's gonna come, but it is a normal finding to have some arcocyanosis right away. We wanna make sure that she has all 5 fingers on each hand, and she sure does. And we wanna make sure that they're not webbed and that she doesn't have any extra. Again, we're gonna check her feet also. She's got 5 toes on each foot, and no webbing and no extra. We're also gonna check the palms of her hands for a Simeon's crease. A Simeon's crease is a transverse line that goes across the palm, and sometimes it's a normal finding, but sometimes it can be indicative of trisomy 21 or Down syndrome. So that's just something that we want to be aware of and look for when we check sweet little Lucy. She looks good. We also want to check her for stork bites, which sounds a little bit scarier than it actually is. Stork bites are red marks that you might see on baby, and they're going to be more emphasized when baby's crying. When you touch them, they will blanch, and they're going to clear up on their own. They're not anything to be worried about. Another thing we're going to look for on her skin would be a strawberry hemangioma. Now these are more raised and they're darker in color. Usually no intervention is needed unless they're larger than 5 centimeters. But that's another thing that we're going to be checking her for. We're also going to look for a port wine stain. A port wine stain is not going to blanch, and it's typically on the face. That's going to be red to purple in color, and they typically do not fade. Sometimes, you know, as baby gets older, and turns into child and eventually teenager, she might want that off of her face. And the only way to do that is with laser surgery. And typically those port wine stains are not ever fully gone. They're just kind of lessened. So that's something to talk about later on down the road. We're also going to look for Mongolian spots. These are typically seen in babies with darker skin tones, and they're going to be seen on the buttocks area and on the lower back. They look like bruises, but again, they're not going to hurt baby. They fade with time a lot of the time. One thing that can be kind of scary is a harlequin sign. So with the harlequin sign, half of baby is going to be pale and the other half is going to be red, and you're going to see a distinct line right down the center of baby. It can last from 2 minutes to 20 minutes, and sometimes that can be pretty scary for mom and caregiver, whoever it is. But that's just another thing that we need to reassure them. It's a totally normal finding, even though it is a little scary, nerve-wracking. We're going to check to see if baby's got some vernix. Vernix is that white coating that protects baby's skin from the amniotic fluid while she's in utero. Babies that are preterm are going to have a lot more of it, and babies that are at term or right around term, you're typically going to find it in like the folds in their armpits. Girls, you're going to find it in their genitalia. You're going to find it behind their knee. Again, nothing to be worried about, totally normal. You might see some milia. Milia is going to be the clogged sebaceous glands, usually on the nose or on the cheeks. little white spots. Again, not anything to be worried about. They typically go away with time. And then we're also going to check the inside of her mouth for Epstein pearls. And Epstein pearls, they can kind of look like teeth, but they're just white papules, and they also go away with time. They're typically on the roof of the mouth or on the gums. So now we're gonna look at baby's chest. Lucy's chest is the right shape. It's just what we want it to be. She's not having any respiratory distress. Everything looks good, so we're just gonna listen to her lungs. And we're gonna use the bell again of our stethoscope. And we're gonna go ahead and listen. Sometimes with newborns, you're gonna hear some crackles in their lungs, which is, again, a normal finding because they've just been floating around in amniotic fluid. So for the first 24 hours, to hear some crackles in their lungs, that's totally normal. But it should clear up after 24 hours. We're just gonna go ahead and listen to baby Lucy. She sounds good. We're gonna look for signs of distressed breathing. So distressed breathing in a newborn, we're gonna see some nasal flaring, we're gonna see some retractions, and we're gonna see some seesawing breathing, which means that they're gonna be sucking up their tummy under their rib cage. That is a medical emergency, and we're gonna need to contact the healthcare provider pretty quick, because respiratory distress, that's not something we wanna see in baby. Sometimes that can happen because, especially in preterm babies, we all have surfactant. So surfactant is the covering of our alveoli, which helps to keep them inflated, to keep them from not collapsing. So preterm babies, they're not going to have as much surfactant because the lungs are less to develop while in utero. So we just want to make sure that we are really paying attention to respiratory system on baby. If she's 27 weeks, if she's at term, we just want to make sure that we do a really good respiratory assessment. So now let's check her cardiovascular system. So we're going to do some capillary refill. We can do it right here on her hands and check for refill. We can do it right here on her feet. We're going to check her pulses and make sure that she's got everything going good. She does. We're going to listen to her heart. We're going to listen to the 4 spots on her heart. Again, we're listening with our bell because it's smaller and baby's smaller. We're going to go to the 4th intercostal space to listen to that apical pulse, which is different from on a grown-up, which is going to be the 5th intercostal space. And her heartbeat is going strong. Now, when Lucy was in utero, her circulatory system was actually working backwards than it does when you're born. So when you're in utero, the placenta has the umbilical cord, and the umbilical cord attaches to the inferior vena cava. So all that oxygenation is coming in from the inferior vena cava from the placenta. So it's going to come into the right atrium, and it's going to come in through the ductus venosus. And that's going to build up pressure in that right atrium. So from the right atrium, it's going to scoot over to the left atrium. It's going to bypass the liver, and it's going to go through the foramen ovale. And that's our second shunt. So I said there are 3 shunts. So the first one is the ductus venosus, and it builds up pressure in that right. It's going to go through the foramen ovale. And then once it's in the left atrium, it's going to go straight from that out to the aortic, through the aorta. And that's going to be our ductus arteriosus. So those are the 3 shunts. So that's how oxygenation is going to go through baby's heart. And then when baby's born, she's going to come out and she's going to take that big first breath, and all those shunts are going to close, and everything is going to rewire and go the other way. Because when baby's in utero, the veins are actually what carries the oxygenated blood. And we know that in grown-ups, veins carry deoxygenated blood back to the heart, and the arteries take oxygenated blood throughout. So that's actually super cool. We're going to look at baby's abdomen. We're going to make sure that it is rounded. Babies typically tend to have a rounder belly, but no distension. We just want to palpate for any masses. She can't tell us if she's tender, but we're just going to watch her face and see if she grimaces or see if she gives us any sign that that might hurt. We're going to listen to her bowel sounds in all 4 quadrants. I'm going to start in the right lower and go to the right upper, then the left upper and the left lower, and see that she's got some active bowel sounds. We want baby to have her first bowel movement within 24 hours, and that's going to be meconium, and it's going to be tarry and black and super fun, really sticky. But after she passes that, she's going to transition, and depending on if mom breastfeeds or bottle feeds, that's going to tell us the consistency of that transitional bowel movement that we're going to get after she does her initial meconium in that first 24 hours. We're also going to inspect the umbilical cord. Like I said, the umbilical cord is what carries the nutrients and the oxygen from the placenta to baby, and she's going to have 2 arteries and 1 vein on that umbilical cord. It probably will not have any Wharton's jelly on it, but when baby's in utero, that umbilical cord has Wharton's jelly on it, and that jelly is just going to keep the umbilical cord nice and slick so that it's hard to be compressed, so that baby can keep getting all that nutrients and all that oxygen from mama. We are going to check baby's hips. We're going to turn her around and we're going to do Barlow's and Ortolani's maneuver on her. So what we're going to do is pull her legs, extend them towards me, and then with our thumbs we're going to wrap around. We're going to pull her knees all the way to the chest, and then we're going to frog her legs out when we do that. So again, we're going to extend the feet, bring the knees up to the chest, and then we're going to frog them around. And if we hear any clicks when we're doing this, that could be a sign of hip dysplasia. We want to be really careful when we do that, to be really gentle on baby. It can be a sign of hip dysplasia. Sometimes it's not. But if we do hear those clicks and clunks, we want to make sure that we talk to the healthcare provider about that so that we can investigate that a little bit further. We're going to go ahead and inspect her genitals, see if she's got anything swollen going on down there. She's probably going to have some vernix in there, so we'll get her go ahead and cleaned out. She's going to be a little swollen. We're going to go ahead and inspect the anus. So we put a gloved finger and just insert that into her anus to make sure we've got some patency. Sometimes little girls can have blood-tinged, it's called pseudo-menstruation, come out of the vagina post-birth, but that's also, again, very normal. If we do see any of that, we're just going to clean that up. We're going to flip her over and pick her up, and we're going to check her spine, make sure that everything is aligned. We're going to check for any sacral dimples or any moles, hairy moles, or any growths along the spinal cord. That can just tell us that there might be something going on with baby, and that we need to investigate that a little bit further. So Lucy looks good. She looks aligned. And last thing we're going to do is we're going to make sure that Lucy is not losing a lot of heat. So there are 4 different ways that babies can lose heat. There's evaporation, from when the amniotic fluid evaporates from baby's skin. So with that, we want to dry baby off really quick and go ahead and wrap her up in some pre-warmed blankets. There's also conduction, and we've stopped that by, we have her little baby blanket on the table that she's laying on. Conduction is when we have a naked baby on a cold surface. So we just want to make sure that we've got something between that cold surface and our naked baby. There's also convection, when the baby's exposed to some cooler air. So we just want to make sure that we're not exposing baby to some drafts, making sure that she's away from the window, stuff like that. And then lastly, there's radiation, when she's exposed to, like if she's close to a cold wall. So we just want to make sure that she's dressed appropriately at all times. So with that, Lucy looks good, and we're going to go ahead and wrap her up and get her back to mama. We hope you've learned everything you need to know about how to do an infant head-to-toe assessment. Thanks so much.